The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. We are gathered here for another episode of TMD Demystified. I am Tony Urbanek. Today's topic is TMD, the most misunderstood disease on the planet. And that is my opinion, and I stick by it. The more I study it, the more I am convinced it is the most misunderstood disease on the planet. I have put 50 years into the treatment of TMD, Temporomandibular Joint Disorder. As most of you know, I'm an oral and maxillofacial surgeon. What I'm finding out is that this podcast is viewed more and more by patients. Actually, it is viewed more by patients than it is by dentists. So I have been making a pivot to address this podcast and these episodes more toward patient knowledge. But I think that it is safe to say that educating patients may be more important than educating the dentist, because the dentists don't want to hear anything about TMD. We'll talk about that in a minute. A little frustrating when you put 50 years into studying a disease and end up with the opinion that it is the most misunderstood disease on the planet. So the other thing I wanted to clarify, and I've talked on before, I've noted before, that on top of a weekly podcast episode, I also do a blog weekly, which is a written blog, which can be read on our website, www.urbanektmj.com, urbanektmj.com. And anyone who wants to follow along can go to that website and get a written copy of what I'm about ready to discuss. So what I'm going to do is I'm going to use that blog that I wrote last Sunday evening and include it in the presentation today, which hopefully will not confuse you, nor will I make it any longer because we're going to do this. But I put a lot of thought into the written blog, and I would like to read that with you, and make comments as we go along as necessary. And again, it's entitled TMD, the most misunderstood disease on the planet. TMD, Temporomandibular Joint Disorder, is a very common disease. 45% of females in the United States suffer from TMD symptoms. If you read the literature, which I have for 50 years about TMD, Temporomandibular Joint Disorder, what you will read, depending on the country that the study is done in, and which university and how many people that are studied, you'll read that the incidence and prevalence of TMD is roughly between 15 and 30%. But what I also found out is that those studies never include all of the symptoms. They just usually include the very localized symptoms associated with pain in and around this joint, and facial pain, and different euphemisms, not necessarily diagnostic terms, but euphemisms like trigeminal neuralgia, which is just a catch-all phrase. Trigeminal neuralgia is a catch-all phrase and really cannot be defined well, if at all. It's a very old term. Prior to trigeminal neuralgia was tic douloureux. Trigeminal neuralgia, all it means is pain, neuralgia of the nerves associated with the trigeminal nerve, which is the fifth nerve that has four sections, one coming up here, one coming up here, and one coming to the mandible. Trigeminal neuralgia. But in itself, it is not a disease. It is description of where the pain is. So, not getting too deep into the weeds, when you include all of the types of symptoms associated with temporomandibular joint disorder, and it is only one disorder, it is not disorders. They like to make it disorders because they, meaning the academicians, and basically I was trained as an academician. I decided at the end of my academic training with degrees in not only medicine and dentistry and cell biology and anatomy, and 2 years as a fellow with the National Institute of Health doing research on facial growth and development, I was trained as a researcher. And the academicians actually are part of the problem because they have not studied the problem in depth. Going on. So the symptoms, when you add all of the symptoms associated with the problem, and the academicians like to just list the symptoms and say that it's a complicated because it has so many symptoms. We're going to get into that and why and how in a minute. But the actual prevalence, incidence of TMD is 45% of females. 45% of females have one or more of the temporomandibular joint symptoms, which are directly related to and caused by inflammation within the temporomandibular joint. That is the discovery that separates anything else, anyone else, any other study ever done, which defines the common denominator of the disease, creating all the symptoms. TMD should be classified as a medical disease because it is just like any other joint in the body. The temporomandibular joint is just like any other joint in the body. But it is treated by dentists. It is classified and should be classified as a medical problem, a medical disease. This joint is no different than any other joint in the body as to how it operates physiologically, pathologically, how it interfaces with the endocrine system, the nervous system. But dental schools claim that this joint is different. It's very unique, which is not true. The vast majority of dentists don't want to treat it. In fact, they don't want anything to do with it because they don't know how to treat it. They don't know how to diagnose it. They do know it is a very complicated disease because that is what they were taught in dental school, and that is true. I have never talked to a dentist, and I have talked to hundreds and hundreds and hundreds of dentists about this problem, and not one of them has ever disagreed that they were taught in dental school, whatever school they went to in the United States, that they were taught this joint is unique, it is complicated, it is unlike any other joint in the body, which really is the first lie. It is not true. The joint operates like any other joint in the body. I mean, if you just use common sense and logic, why would the entire body and all these other joints operate with the same pathology, with the same neuroendocrine system working in the same way, and somehow this joint was going to be different? Does not make any sense. 50% of dentists tell patients they don't treat it, and 49.99% make a night guard for the disease and hope the patient does not return because they know a night guard does not treat TMD. There are some dentists who actually believe a night guard treats TMD. A night guard meaning a piece of plastic, acrylic, that goes over the teeth. And the purpose of a night guard is nothing more, nothing less than to protect the teeth if you clench or grind the teeth while you are sleeping. That is, and it is a valid purpose to make a night guard if you want to protect the teeth. But a night guard has nothing to do with treating inflammation in this joint. In fact, very often it makes it worse. And we have majority of people come in who have been given a night guard and said it just makes it worse. Why? Because it just gives them something else to chew on between their teeth. And they'll fracture the night guards and they'll chew through the night guards all the time. But a night guard is valid for protecting the teeth if you clench or grind, but doesn't do anything to decrease inflammation within the temporomandibular joint. Then there are 0.01% of dentists I call TMD gurus who try to treat the disease using smoke and mirrors and game the medical insurance companies to pay for their nonsense treatment. This is a fact, and I stick by it. Doesn't give some dentists a good point of view. It doesn't put them in very good light, but that is what I have observed over the past 50 years. First, treating temporomandibular joint for 36 years as an oral maxillofacial surgeon, doing over 2,000 temporomandibular joints cases, 2,000 hospital operating room cases on the temporomandibular joint, half of them through an arthroscope and half of them open joint surgery and making an incision in front of the ear. But I had to observe the entire time my colleagues, my dental colleagues, who were classified as TMD gurus, hooking up the patients up to machines and doing all kind of things, and then applying for medical insurance to pay for it. Again, TMD is a medical problem, just like knee inflammation and damage, hip inflammation and damage. Elbow inflammation and damage is a medical issue. It is not covered by dental insurance ever. You're not going to have a knee inflammation and bone loss and damage covered by dental. Well, why would this particular joint be covered by dental insurance? It isn't, but it isn't covered by medical insurance either, because the medical insurance patients don't want anything to do with it because the dental schools teach it's unique and different and unlike any other joint in the body. It's circular. It just goes round and round in circles. The most recent example that I can think of is the use of botulinum toxin A, better known as Botox, injected into the symptomatic areas, paralyzing the muscles and relieving pain because the muscles no longer work at all. A recent scientific study published in the January issue of the Journal of Oral and Maxillofacial Surgery has statistically proved, that injecting botulinum toxin A and saline into the facial muscles, particularly this big muscle right here is what the study was on. It's called the masseter muscle. Injecting botulinum toxin A, Botox, into this muscle and saline into this muscle gives the same result. Tells you what Botox is all about. But there is an increasing large cadre of dentists who promote the use of Botox because they are sold on the concept that it fixes the problem by Botox salesmen and advertising literature. They admit the biggest advantage of Botox is the patient must return for further Botox injections every 3 to 4 months. I actually have a patient who swore to me, and she said, I can bring in the receipts from the Botox injections that I and my insurance company have spent over $200,000 on Botox injections over 10 years. It was 10 years, $200,000 over 10 years. That's $20,000 a year. And that is what she said. And she said, I can bring on the results. And she was sitting in my office with the initial symptoms she started with the Botox. Proves the point. Amazing, just amazing. What they don't want the patient to know is botulinum toxin A, Botox, is not approved by the FDA to treat TMD. And that dentists or anyone else who is using this to treat TMD symptoms is using it off-label. That is a fact. No one's going to disagree with me on that because it's not approved by the FDA. It is approved by the FDA to remove and help with wrinkles if you want it to. So, number one, there's a lot of nonsense going on, and anybody who has this problem for any length of time is, number one, run around in circles with their providers and eventually come to their conclusion, that there isn't a solution. Nothing works. There isn't a solution. That's the story on dentists. Physicians, on the other hand, don't want to do anything with TMD for the same reasons as dentists. Physicians know they don't know anything about TMD. Problems with the temporomandibular joint are not addressed anywhere in medical school or specialty training. If a medical doctor suspects their patient has TMD, he will tell them, see a dentist. Both dentists and physicians agree on one point. The consensus is, when it comes to treating TMD, nothing works. Again, I have talked to hundreds and hundreds and hundreds of dentists about this, and the vast majority of them, excepting for the TMD gurus using smoke and mirrors, agree that nothing works. The most prominent complaint is they don't want anything to do with TMD patients because whatever they try to do, they know the patient will always be back coming back to the office time and time again with the same symptoms, not knowing what to do about it. The provider, the dentist, has already used the night guard, and patients come back for another night guard because they chewed through it in another night guard. On occasion, patients will come in our office with usually a paper bag, sometimes a brown paper bag, and shake the paper bag and said, would you like to see what I've been being treated with? And my response is, no, I already know what's in the paper bag. A bunch of night guards. Yeah, it's true. You can see how the patients are led around in circles from physicians to dentists to gurus, back to physicians, and then back to dentists, sometimes for decades. The average patient that sees us in our office has been seen for, on average, 5 to 10 years by multiple physicians and dentists trying to solve this list of symptoms that they have been complaining about. There is so much confusion about this disease that it is even named wrong. Everyone calls it TMJ. TMJ is just the name of the joint. Everyone says, I have TMJ. I got news. Everybody has 2 TMJs. Everyone, dentists, physicians, and patients for the past 60 years call the disease TMJ, which is the name of the joint itself. Do you go to the orthopedic surgeon with knee pain and announce you have knees? I repeat, TMD is the most misunderstood disease on the planet. This description is the state of art for treating TMD in the United States of America in 2025. It is the current state of art. Very pathetic indeed. Dentistry has gotten itself into this conundrum for 2 reasons. First, dentists are taught that TMJ is unlike any other joint in the body. It's different, they're taught. It's unique. We don't know what's really going on with it, and we're not smart enough to figure it out in dental school, so you're certainly not able to figure it out, young dentist. That's the message that these doctors get going through dental school about TMD. Don't bother looking. It's complicated. Don't bother looking. It does have a complicated name. Unique name, gangliomo-arthrodial joint, gangliomo-arthrodial joint. Arthrodial meaning sliding and gangliomo rotation. It has two different mechanisms for motion, but that doesn't make it a different joint. That doesn't make it a different operational structure within the body just because it has a complicated name and it has two types of movement, a rotation and a translation. That doesn't make it complicated. And second, the symptoms of TMD can be very confusing. This is true, that symptoms of TMD can be very confusing unless you come to the conclusion that all the symptoms are driven by a common denominator, the common denominator being chronic inflammation within the temporomandibular joint. Each and every joint that I operated on over the first 36 years of my career, the last 14 years I've been treating TMD non-surgically, but the first 36, I treated it surgically, and every one of those over 2,000 surgical cases, a specimen, a piece of tissue was sent to the pathologist in the hospital, standard operating procedure in an operating room in a hospital. If you do surgery, you are going to send a piece of tissue to the pathologist, and I sent out over 2,000 pieces of tissue out of 2,000 cases, and the result, first line of the pathology report on each and every case, 100% of the time was chronic inflammation. No matter what else the pathology report included, and it could include many things, but line one of the pathology report was always chronic inflammation or a description of the cell types that make up chronic inflammation. So you can deduce that chronic inflammation is involved with, one way or another, temporomandibular joint disease. It is consistent. But there are multiple symptoms caused by chronic inflammation within the temporomandibular joint. And those symptoms include frequent and/or recurring headaches, earaches, neck pain, jaw pain, ringing in the ears, a feeling of fullness in the ears, which we call subjective hearing loss. You go to the ENT doctor with, say, I can't hear out of this ear. They do a very extensive workup by the audiologist and are told, we don't find anything wrong with your ear. And the patient says, no, I'm telling you, I cannot hear well out of this ear. And that is called subjective hearing loss. And subjective hearing loss is one of the most common symptoms associated with TMD. Beyond subjective hearing loss and fullness in the ears, dizziness and vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Those are the most common. Those are well accepted by everyone symptoms of TMD, temporomandibular joint disorder. It's not disorders. The academicians want to call it disorders because it has these various symptoms, and every symptom is a disorder. No, is multiple symptoms created by one cause, chronic inflammation within the temporomandibular joint. And then if you attack and can attack chronic inflammation and make that go away, you have solved the problem. All the physicians and dentists know that non-steroidal anti-inflammatories, which would include aspirin, Motrin, ibuprofen, work really well on chronic inflammation, and patients get usually really good results for temporomandibular joint symptoms if they use non-steroidals. But the problem with non-steroidals is they're time limited. You rarely get more than a couple weeks out of resolution using non-steroidals, and they run out of steam. And every physician and every dentist knows that. That is not unique at all. So it actually proves the point. If there is a better way to get rid of chronic inflammation than non-steroidals, which only last a few weeks in effectiveness, then you have the problem solved. But there is a laundry list of symptoms that are associated with chronic inflammation, and it confuses the physicians and the dentists all the time. Also included in this limitless, also included are the limitless kinds of joint noises, visual disturbances, and occasionally what patients believe is tooth pain in these symptoms. Those take a greater amount of discussion, including visual disturbances. Visual disturbances have been historically the line in the sand drawn between migraine headaches and any other kind of headache. If you have visual disturbances, it will automatically be described and classified as a migraine headache. Unfortunately, for the migraine headache doctors, we are seeing an increasing number of people whose facial pains, jaw pains, earaches go away, including their visual disturbances. And that is a scientific study that I have also done. The dentists and physicians simply try to treat symptoms, which change type, characteristic, and location constantly. They'll come into a PCP and they'll say, some days it hurts right here, and the other days it hurts here, and sometimes it hurts right there. And the explanation for that is very simple. Chronic inflammation sends signals to the brain saying, I'm inflamed. The brain says, I'm going to help you out. Don't move the jaw, and sends various signals at various times to various muscles that move the jaw, not always the same muscle, not always at the same time, and the symptoms of pain move around as the muscles get tight and pull on the bone, where the pain receptors are located on the coverings of the bone. That is the real mechanism for TMD. The actual mechanism for TMD is chronic inflammation, signals the brain that it's inflamed. The brain says, I'm going to help you out. Don't move the jaw, tighten the muscles, but send signals not always to the same muscles. They send signals to various muscles that move the jaw. There's a bunch of them. There are 5 major ones. And where those muscles get tight and where those muscles pull on the periosteum of the bone is where it hurts, because that's where the pain receptors are in the covering of the bones. And so patients will point right here to the malar eminence or the zygoma or the temporalis muscle where it's attached here, or the masseter muscle where it's attached here, and say, this is where it hurts. And then the gurus put Botox in the muscle, paralyze the muscle for 3 months, and then the pain comes back, at which point, and the muscles move around. I mean, they Botox this side, and then it hurts over here. It's an amazing thing that's going on out there. And additionally, physicians misdiagnose TMD and as migraines. The science on migraine headaches, at scientific papers on migraine, and the science on migraines, and good scientists, and they're trying hard, they admit they do not know what causes migraine headaches. But we have seen consistently what cause bad headaches, recurring headaches, from temporomandibular joint inflammation that have been misdiagnosed as migraine headaches. And patients have been on migraine headache medicine for 10 or more years, thinking that they have migraines when the cause is inflammation within the temporomandibular joint. So physicians misdiagnose migraines, Meniere's disease, which is ringing, fullness, dizziness, tinnitus, subjective hearing loss, vertigo. That's Meniere's disease. The ENT doctors admit they have no solution for Meniere's disease, but those 3 symptoms are well-known symptoms associated with TMD. And we now know that inflammation within this temporomandibular joint has a proximity to the middle ear through an actual structure, a fissure that goes from the temporomandibular joint inside into the middle ear. It's called the petrotympanic fissure, that was first observed and noted and written upon by a Dr. Johann Glasser in 1680. That is 350 years ago. Dr. Johann Glasser described the petrotympanic fissure, also known as the Glasserian fissure, which allows inflammation, specifically inflammatory fluid, through a fissure goes from the temporomandibular joint into the middle ear, where the hearing mechanism and the vestibular mechanism is located, which are the mechanisms that allow you to hear and keep you upright, so you're not dizzy. ENT doctors have no solution for Meniere's disease, and we have patients constantly come in with the diagnosis of Meniere's disease that have inflammation in the joint. It's easy to diagnose if they have the symptoms and you push on a joint firmly from the open to the closed position and it hurts, the joint is inflamed, similar to any other joint in the body. If you have a bad knee, the orthopedic surgeon is going to walk across the room at the onset of the examination and squeeze your knee to see whether it hurts. If he squeezes your knee and it hurts, the orthopedic surgeon knows that the joint is inflamed. The common denominator of joint damage is chronic inflammation. Chronic inflammation. So physicians misdiagnose TMD constantly as migraines, Meniere's disease, and ear infections. I can't tell you the number of patients who present to us who have been to multiple walk-in clinics with ear pain and walk out with a diagnosis of ear infection and a prescription for antibiotics that obviously don't work because they don't have an infection. They have is inflammation within the temporomandibular joint right near the external auditory canal. Actually, there's a paper thin area, literally paper thin, that allows inflammatory fluids into the external auditory canal, giving the sensation of pain and giving the sensation of earache. Not diagnosed as ear infection, diagnosed as TMD. So the truth is the TMD operates like any other joint in the body. The temporomandibular joint is not different. It is not new, it is not unique. The research I did beginning 14 years ago confirms it. This research, now supported by independent university studies, shows all of the symptoms noted above are directly driven by chronic inflammation within the temporomandibular joint. Instead of trying to treat the constantly changing and disparate symptoms, and I guess you could include disparate and desperate because the patients are desperate sometimes. Instead of trying to treat the constantly changing and disparate symptoms, treating the cause, inflammation, by unloading the joint with a small intraoral device, allowing the inflammation to dissipate, will in turn make all the symptoms dissipate and go away. It is very simple, yet elegant. This device is called the Urbanek Device and Protocol. You can read more about it. You can look more about it. Look all you want at all of our areas of interest, the entire blog, hundreds and hundreds of success stories and descriptions of exactly how it works at urbanektmj.com. www.urbanektmj.com. I can say with authority and certainty, TMD is no longer the most misunderstood disease on the planet. What wasn't understood was actually what drives all the symptoms. For the past 60 years, the dentists and dental schools and dental investigators have looked at just how to treat symptoms. They have not looked at the common denominator. They have not even thought about looking at the common denominator and the best way to treat the common denominator. The best way to treat TMD is to unload the joint over a period of time, according to a protocol and a device that unloads the joint, just like a set of crutches unloads a damaged knee. If you had a very damaged knee, and the orthopedic surgeon says, we're going to have to do some surgery on the knee. And if you said, no, I don't want to do surgery on the knee, what else can I do? He would hand you a set of crutches, rightfully so, truthfully so, and he would be 100% correct in saying, you will not have knee pain anymore if you stay on the crutches. Well, that's exactly how a device that unloads the temporomandibular joint over a period of time, according to a protocol, works. Again, I'll just repeat. TMD is no longer the most misunderstood disease on the planet. if you know how TMD is generated, how the symptoms are generated. With that said, I won't go on. I hope I have not droned on too long for you. I hope my explanation has been clear. Until next Tuesday, when I do my next episode of TMD Demystified, I am Tony Urbanek.